Greetings to everybody, and thank you to the organizers for this opportunity. I am Collins Chenwi, a clinical virologist from the Chantal BIYA International Reference Center, Yaoundé, Cameroon, and currently finalizing a PhD at the University of Rome Tor Vergata in Italy. Today, I'll be presenting to you our work on the monitoring of HIV drug resistance to integrase inhibitors in Cameroon. So, we've been observing varying and even worrying rates of INSTI resistance so far in resource limited context, but then the patterns and maybe clinical case scenarios favoring these emergence are not fully understood. We therefore sought to evaluate levels of HIV drug resistance to INSTI and describe any associated clinical factors among people with HIV on DTG-based regimens in Cameroon. In Cameroon, it's worth noting that DTG was introduced in 2020. So it's been just like 5 years since its introduction in this setting. We carried out a cross-sectional study at the Chantal BIYA International Reference Center. This center receives almost all cases for genotyping from all through the country. The threshold for viral suppression is still 1,000 copies per milliliters, and we perform genotyping in RT, PR, and integrase. So overall, we had 144 individuals, among whom 36 benefited from RT-PR integrase, and 108 were not able to sequence the integrase. The median viral load was 4 log at failure. These individuals had received antiretroviral treatment for about 8 years, a median of 8 years, and the DTG-based regimens had been used for a median of 14 months. CRF02AG is the predominant viral clade in this population. So, with respect to the rates and patterns of resistance, this graph here shows in the blue bars the rates of resistance in the individuals who benefited from RT-PR and integrase sequencing, and the orange bars the rates of resistance in those who benefited just from RT-PR. So we see here that clearly for the other classes of resistance, they are not too different in between these two groups. But then integrase resistance in the evaluated population was 38.9% yes. So 14 out of 36 of these individuals presented with at least one major mutation to integrase inhibitors. We think that if we perform sequencing in this whole population, it's going to be similar or at least substantial still the rate of integrase resistance. So in these 14 cases, we observed some key clinical scenarios we would like to show to you today. We can encourage you to look at the poster for more details. There's more details on the clinical and virological aspects of these individuals. But then the first clinical case scenario were individuals transitioning from NNRTI-based first line to DTG with unsuppressed viremia. So we believe that failure on first-line regimens may have contributed to these 5 individuals. The second group of 5 individuals were using DTG-based ART in third line without appropriate NRTI selection, so without the use of genotypic resistance testing. And the third group were individuals who were co-treated with rifampicin containing anti-tuberculosis medication. It's worth noting that 3 out of these 4 individuals all benefited from the dose adjustments which are recommended with DTG. Apart from that, those with resistance were older than those without resistance, and the median duration on ART in those with resistance was about 24 months. So the mutational patterns, we observed 3 main patterns. We did not observe the Q148 pattern. We observed these 3 patterns. The majority pattern observed was the G118R, present in 9 individuals and always present with at least 1 or more DRMs. Second, we had R263K plus or minus 1 DRM observed in 4 individuals. And the last was N155H plus 3 DRMs observed in 1 individual. So we already see that most of our cases are cases of high level resistance to integrase. And even if we maintain DTG, we may not even have any beneficial effects. So looking at the subtype, it's worth noting this observation that G118R appeared to be more present in the 02AG subtype. 7 out of 9 of them were from 02AG, while R263K rather appeared more in the non-02AG subtype, so 3 out of 4 of them. So there may be a link with this subtype distribution. In conclusion, we'll say among various unsuppressed people with transitioning to DTG containing R, instill resistance is substantial by the second year following transition in this setting. Therefore, ensuring viral suppression at transition, genotyping guided R for third line, or DTG sparing regimen with rifampicin containing treatments would contribute in mitigating instill resistance in low and middle income countries. Thank you very much for your attention.